So, just so we all on the same page, we'll start in just a second. We had a couple technical issues, so okay, we'll give it one more second and I'll go ahead and start. All right, I'll go ahead and start now. So, good morning, everybody, and welcome. This is our national webinar on strengthening HIV prevention and mobile health services. My name is Lawrence Vinson III, he, him, his, and I'm a national senior program manager on the national consulting team. I work in the intersection between health and housing here at CSHO, which is Corporation for Supportive Housing. I'm a certified community health worker in the state of Massachusetts, and I come with over 15 years of experience working at all levels of chronic disease management and HIV care. That includes direct service, program design and management, community engaged research, state public health, and Medicaid policy and financing. So I've spent time on both sides of this, doing the work on the ground and trying to figure out how to keep paying for it after the grant has ended. And I'm joined today by my coworker, Becky Moses, who'll be carrying a good part of this with me this hour.
Thank you so much, Lawrence. It is a pleasure to be here with you all this morning. My name is Becky Moses, and I'm also a senior program manager for the Corporation for Supportive Housing, and I'm in our HRSA division. So, like Lawrence, I've been on both sides of the field, so a lot of direct service, mostly in housing, but the last 5 years of my career have been dedicated to HIV linkage to care, health departments, just all that type of work. So I'm excited to be here to help facilitate today's conversation and pull out some of the brilliance that I know is in this audience. So Lawrence, I pass it back to you.
Thank you, Becky. So just as a reminder, this webinar is part of HRSA, or the Health Resources and Services Administration's Bureau of Primary Care Year 3 Training and Technical Assistance. One quick word about what Becky and I bring and what we don't. I've been in the HIV work for about 15 years. As I started as a counseling tester, medical case manager, spent time in linkage to care, the state STI prevention, and all of those things. And now I work in that intersection between housing and how housing services get paid for. Neither of us is a mobile HIV clinician. So when we're in the clinical material today, I'll tell you exactly what these guidance were cited, and and you will get a copy of this in the presentation afterwards. When we get to Medicaid waivers, housing, and partnerships, that part we do every day very well. Also, just some housekeeping. We are recording, and the recording and every resource will go up on the CSH Technical Assistance page and the National Resource Center Clearinghouse. Uh, put your questions in the chat as they come to you. We'll be monitoring that. Whichever of us isn't speaking is watching the chat, so nothing gets lost. And we'll open the floor to questions about 40 minutes in, 40-ish minutes in. So there's real time for them, not to rush those minutes at the very end, but we're going to make sure we set aside that time for you. So let's get into it. All right, so 4 things we want you to take away with you today. Number one, describe the evidence for integrating HIV prevention and substance use disorder treatment in mobile setting. Number two, identify at least 3 strategies for engaging, retaining homeless individuals in mobile-based HIV prevention. Number three, explain how cross-sector partnerships, housing, behavioral health, and Medicaid strengthen the referral network around mobile programs. And number four, apply practical frameworks for data-driven monitoring and quality improvement. So here's the shape of the hour. We'll start with context, that overlapping epidemic driving all of this, and then integrated service delivery, what's actually going on the van, then engagement, how you build trust with people with the system that has already failed them, And then partnerships, the network that turn a screening result into an actual service. And when we close on data and sustainability and your questions, each block's build on one before it, from the why to the how to what's next. All right, so context. Oops, I'm sorry, this is, okay, here we are. Overlapping epidemics, compounding risk. Okay, we're not talking about one health issue today. We're talking about overlapping epidemics. Housing instability, substance use disorder, and HIV form a risk triad, and it lands hardest on people who are homeless or unstably housed. First, HIV and housing. Homelessness and unstable housing are associated with increased risk of acquiring HIV and Hep C. That's especially true among people who inject drugs. Substance use and transmission. People who inject drugs accounted for 70% of new HIV infections in 2020. And I want to say that year out loud because it matters. That's from the CDC's HIV surveillance report from 2020. It's the figure that Phil cites, and it's the one on this slide, but it's 6 years old now. If you're building a local case, go pull the most recent volume. Third, the barriers to care. Lack of affordable housing, untreated behavioral health needs, fragmented services and systems. Each one pulls distance between a person and a screening and a prevention service or a linkage to care. Mobile health sits right in the middle of that because it removes the most basic barrier of all of them, the requirement that somebody comes to you. Four numbers to frame the problem and the opening. Okay. 51 per, 51.8, I'm sorry, 51.84% of patients ages 15 to 65 tested for HIV. That's the share of health centers for patients aged 15 to 65 that tested for HIV in 2020 using the UDS system or the Uniform Data System. And the note at the bottom of the slide says health centers now exceed the Healthy People's 2030 screening target. So the story here has changed. The headline is no longer a screening gap to close. It's the field made a real progress, and the work now is sustaining it and reaching the people who are still hardest to find. The next number, 533,000 patients screened positive for housing insecurity. That's about 2.24% of health center patients. And that number understates reality because not every health center screens consistently. 7% of new HIV infections in 2020 came from people who injected drugs. That's precisely the group mobile health is built to reach. And 25 states now have 15 waivers covering housing related services. That's a sustainability pathway that did not exist at this scale 2 years ago. We'll come back to that one. It's the single most useful thing on this slide for anybody trying to pay for this work, especially getting people linked into housing care. So why mobile health services? Because mobile services remove the most fundamental barrier. We said it before, requiring people to come to you. Now you're there. You meet people where they already are, shelters, encampments, community spaces. You lower the barrier to entry. No appointment, no transportation, no insurance verification before anybody gets seen. You build trust through presence. You show up in the same place on the same schedule, and the familiarity does work that no outreach flyer can. And you enable an integrated encounter, one visit that can carry HIV testing, PrEP education, substance use treatment, naltrexone, and housing navigation all at once. Now, proximity alone is not the point. Getting closer to people is necessary. It isn't sufficient. The power of mobile health is in three moves, and they are how I organize the rest of this hour. Show up, do it all at once, and come back. Show up where you've been, do it all is next. Becky's going to take us through what actually goes on in the van, and then come back is the back half of the hour, and that's where where most of the programs get lost and they lose people. I'll let Becky take us to the integrated service delivery really quickly, and then we'll come back to what happens next.
Thank you so much, Lawrence. So I am excited to talk a little bit more about what integrated service delivery models look like because I remember when I was working back in Philadelphia and we had a mobile health unit. And as you can see, we're just going through a little tech issues. So I'm going to talk through until we get the PowerPoint back up. But I remember working with one of our mobile health units, and I would say that they were some of the most impactful clinicians and providers that we had because, like Lawrence said, they actually came to the environment and got to know our clients. I think Lawrence, we're on slide 8. So they got to know our clients and we're able to sit there and talk with them and build that rapport and really build the rapport before they actually walked into that door. So I just wanted to say that, if we have any mobile health people on this call, very happy that you are here today because you are doing some great work for our populations who need it a little bit more. So give us 1 second to get back and we can go to that next slide, Lawrence. All right. So you guys forgive me too, because now my computer is going up. All right. So here is the shift this whole webinar is built around. Most mobile health programs start with real intent and still end up operating in silos. And I think that goes for any type of work we're doing, right? We might have this intent that we're all going to be collaborative, but naturally we all go into our own little areas, right? So when you look at the left column, you see that people are screening, when you're talking about the silo mobile services, people are screening for HIV, but there's no substance use treatment capacity on that van. So we're missing out on, a whole population. They might do some testing, but they can't start PrEP or antiviral therapy on site. Oh, I'm happy to see that. I saw that in the chat. Thank you. 14 years of HIV outreach services. Can't wait to pick your brain at the end of this webinar. So they engage somebody, but there's no plan for keeping them, right? And that's why my mobile health unit back in Philadelphia was so impactful because they came out every 6 weeks. So everybody knew on this particular day, CHOP night was going to happen. I'm going to see the same people rotating through. And they might identify housing need, but don't necessarily have referral pathways to send it down. So every one of those gaps means another visit before anything connects. And then let's look at the rights column. So when we look at what integrated mobile services look like, we see that HIV testing, substance use treatment, and primary care are all co-located. PrEP and medication assistance treatment started in a single encounter. So it's not me having to come back every 5 minutes, or every week to get a service that I can be referred to in one day. A warm handoff to ongoing care is built into the workflow, not improvised at the end. So the goal is to get them treated, but then also send them off to somebody else as well as every one of those gaps. I'm sorry. And then housing navigation begins at the point of contact. So as soon as I'm meeting with you, we're starting that process right there. So one visit, a comprehensive response. And the reason why this matters is because there is so much, excuse me, it's so much cohesion that has to go on with this one. Every additional visit requires is a every additional visit you require is another chance to lose somebody. And for people living outside, there may not be a second chance at engagement. So Lawrence, we can go
That's
to the next.
so important. Yep, that's so important to make sure that you are engaging and they're seeing the same person over and over again.
Yes. Thank you for that, Lawrence. So when we look at what core service bundle for mobile health, mobile HIV prevention looks like, it looks like this is the service bundle we'll point you towards. And I want to be clear up front, almost nobody delivers all six on day one. This is the direction we move in, but it's not a bar to clear before you start. So the first three are all HIV specific. We want to do the rapid HIV testing, we want to do the PrEP initiation, and we want to do the antiretroviral therapy access. Because with the HIV testing, that's their first point of care. It provides immediate results and it provides counseling attached to that. And that is so key. Anybody who has worked in diagnosis knows that that is a very key moment. And some people are not ready for anything else that comes past those first three. So let me at least get you tested, get you your results, and then, possibly do some counseling if applicable. And if somebody does not have HIV, maybe we want to start talking about PrEP, especially if somebody's living out on the streets and fits any of the demographics we just discussed. And then if we do need the ART therapy access, linking somebody immediately who is newly diagnosed is key in that first area or in that first step. So those might be your first three steps that you do at that time. And then when we look at the next three, what they address, right? We talk about substance use treatment, behavioral health, and housing navigation. Now, when we look at this, we might not be able to do all six of these things because those are six very major things at one time. And somebody just might not be ready. They might just the first column, the first row, the testing, PrEP, ART, whatever it is, that's a lot for somebody to take in. But then we're talking about SUD treatment, behavioral health, housing navigation. That's a lot. So you might only get to the first three and then possibly housing navigation. Because I remember working at the health department and clients would tell me, Miss, I'm not worried about taking any type of medication until I have somewhere to lay my head. How can I store these medications if I don't have a refrigerator? Whatever it is. So you might only get to the three or the four, and that's okay. But Lawrence, I know that you did a lot of linkage to care work. So I wanted to know if you wanted to elaborate on the slide.
Yeah, one of the things that's really important is make sure that you remember your testing kit. If you're using a fourth gen rapid testing, that is very, very good, and it actually gives you a preliminary confirmatory. Running a second one, while if you do get a preliminary, to make sure that this one is not negative or indeterminate. Making sure that you have your workflow set up so that if you do get a positive test for HIV, that there's someone that's already waiting there to get them and take them and get them linked into the services that you saw below. So the substance use treatment, the behavior health, the housing navigation. Now, if that is you as that person and you're also the counseling testing, you need to make sure that there is someone else that's there to take over for you if you do get a positive test. One thing about the PrEP initiation is making sure there's a workflow that's set up for each one of these routes. So if they're negative, but they qualify for PrEP, that should be in some of those questions that you're asking through conversation, of course, where they are. And if they are, high risk and they pass that qualifier eligibility screening that you have, then you send them through that route in the workflow if they qualify. If they are positive and you know that they need to be linked, or if they need to be linked back into care, or if you're also providing STI testing as well, you want to make sure that you talk about ART or antiretroviral therapy and that linkage that they have. If they're newly diagnosed, if they've been out of care, maybe they need services being linked back into care. Or if they, which I've seen previously, if you've had someone who's new to the country, immigrant, they're coming, they don't know the services, they need to be linked into care. That's also another point of access to get people on ART therapy.
Thank you so much for that, Lawrence. Let's go to the next slide. This is probably one of my favorite ones. When we talk about building that multidisciplinary mobile team model, right? Because when I'm looking at the slide, right, we look at the people that you might want to have. Of course, you will want to have a medical provider, a behavioral health clinician, a peer navigator or a community health worker, and a case manager on there that can, handle all these different areas. But when I look at this right now, I'm not sure about anybody in here. And again, if you have HIV experience, please be in that chat because we will be checking the chat, reading some of your stuff out. Um, I know people that will come to the health clinic who know they need to have an HIV test, but are not ready whatsoever. They will come and see that behavioral health clinician. They might come see that case manager. They might even come see that peer navigator, and they might come see them every couple of weeks or whatever the frequency is for months until they feel confident enough and just even loved enough to go and take that test. Or it can be flipped around. I might know that I need to get that HIV test, but I don't want to seek any other services, right? But having those critical roles on that bus will help just in case, somebody, like we said, we meet people where they are at. So when we look at this multidisciplinary team model, this is where we are meeting people where they are at. And it's a critical thing that we must remember that this is not just a medical team. The peer navigator role is especially critical when it comes to this because I have people that will not talk to a doctor, but they will talk to one of their peers. And it's that peer that has to build that relationship with them, right? That person is often the very first point of contact and the very first point of trust, the one who builds the relationship that makes somebody willing to engage with anything clinical at all. So I would love to hear if you have any experiences in the chat as we go along this presentation. But just remember, these four principles hold the team together. Everybody is trained in psychologically informed care, designing around what people have been through and not just what they need clinically. Foundational and not an add-on. And we are prioritizing hiring staff with lived experience of homelessness, substance use, or recovery. We're also cross-training so every team member can run a basic screening and the van doesn't stop when one person is out. And Lauren said that brilliantly just a little while ago, saying like, if we do get a positive test or if you do have like for anything can happen on there, somebody can have a breakdown, whatever it is, the HIV testing process can be very traumatic. You never know if you're going to have to de-escalate somebody in that moment. So making sure that everybody is cross-trained to be able to handle, a situation if it arises, will help us out. And then we also want to build supervision and support structures because this work can burn you out. I always tell people, and it's a beautiful story, but I did leave direct service because I knew I'm like right now at this stage of my life, I can't pour into anybody, right? So sometimes this role can burn you out. So making sure that we have the supervision and support structures that are in place so we can have our staff understand that regardless of what somebody does, if they have a great conversation with you and never show up again, you don't internalize that and understand that you did what you could do and maybe you planted a seed, but you might not be here to see that water. And we can
Burn,
go
and I'll
ahead.
say burnout and retention is a real staff problem, especially that, which is why making sure everybody is trained is really important. As they're listening to somebody and they're, loading on whatever that person is going through that experience, especially if they are positive, that is a source of them holding on to that issue. So making sure that that supervision, but also clinical supervision is provided. Clinical supervision is different from supervision because it is a therapy touch to it. So if you are designing your program, please make sure that you build into there a clinical supervision. You don't have to get someone from your department to do a group clinical supervision unless you want to. There are also programs that allow a person and really schedules it into their weekly pattern to go see their own individual therapist as well as a form of clinical supervision so that they're not holding on to all of the community problems by themselves, but they're able to locate and to pick up trends, give that to the supervisor so the supervisor can adjust what they're bringing. One thing to also mention is the case manager is really important, especially for those patients who may not have test positive for HIV, because they can also do benefit enrollment. So if you are working with the substance abuse population and there is a sense of homelessness, that's there being able to do an assessment, maybe do an enrollment into Medicaid, depending on what state you're in, get them linked to other services that they may need as well. So having some type of someone that's on the team that is a case manager, it does not have to be the medical HIV case manager, but whoever that person is, it can be a combination of peer navigator, community health worker, case manager, whatever that looks like for you. And when you're using your mobile van, that's really important position to have on the staffing person.
Thank you for that part. And that's why Lawrence and I work so well together because he's a case manager slash CHW and I'm the case manager. So we have that flow. We see how we all need each other together. So Let's talk a little bit about how that mobile encounter workflow looks like. So is of course in 5 stages. First contact and it's the first contact to ongoing care. So the stage one is outreach and engagement. So a peer navigator makes contact often outside the van entirely, and that can be at a shelter, at an encampment. And the goal here is relationship, not assessment. And I cannot stress enough, one of the best things that I saw was back in Philly when we had our chop nights where they would come and set up shop in our basement and you would have everybody there. You would have dentists, doctors, behavioral health, you would have case managers, whoever you need, they were there. And the goal was to build that relationship and also the consistency every 6 weeks. And this was going on for years, right? Even during COVID. So the goal was to really build outreach and engagement so they can see, like, hey, these faces that you see right now are going to be some of the same faces you see when you come into the clinic. And that leads us to stage two, which is screening and assessment. So once somebody is willing to engage, you screen comprehensively for HIV, for substance use, for health-related needs, behavioral health, all in one sitting. So there's a caveat to that one. We know that that can be very traumatic depending, like we've seen people go through different type of assessments and you're like, "Ooh, wait a minute, I didn't know I went through all of this. I didn't realize I went through all this trauma." So again, that relationship is so key because after somebody has been screened, you might have to do, a little bit of damage control. You might have to do some de-escalation to get them back to center. Because again, we want them to come back. But if somebody leaves that room feeling like exposed, you might not see them again, or you might see them again a little bit later. And then that leads us to stage three, the on-site services. So whatever can happen now, let's do it now. So testing, prep, medication assistance, treatment, whatever it is, let's make sure that we get that done now. And then stage four, that leads to our referral and navigation. So when I was at the health department in New Orleans, I would tell people when you are calling me to be linked to care, I only want you to call me back to give me a praise report about how everything is going. I do not want you calling me back for the same issues because that lets me know that maybe I didn't do my job all the way in the screening part because maybe I might have missed something or maybe it might need a couple of conversations. I would have people call the linkage number just because, like, I was the only person that they feel like they can talk to, right? So, but what I'm saying is when we talk about referral and navigation, or we want to make sure that we are linking people to the right services in that time. So, what can be met on the van, such as housing, ongoing behavioral health, benefits, the team that is on the van, we would do a warm handoff. And we know how critical that is. Walking somebody there, talking to them, sitting in on those initial appointments, encouraging our clients to speak their truth and not just get quiet. How many times do we go somewhere and instead of voicing our discomfort, we just keep it in. And we know that either we're not going to come back anymore or whatever it is. So we want to eliminate that by doing those warm handoffs and being that sense of support for them. And then the stage five is follow up and retention. So a schedule, a return visit, and a community health worker can do outreach in between. And I cannot stress our community health workers are some of the most important people in the medical industry because, again, we're building those relationships. And you guys know some of the stuff that even case managers don't know because you're in that community a little bit more than we are. So stage five is the one that most programs do skip. And I understand because once we get somebody linked, we got somebody else coming in. We got multiple people coming in. But we see that when that is the one that really matters the most. So the goal is continuity, not just a one-off. And Lawrence, this is where I'm gonna pass it back to you to continue the conversation.
Thank you, Becky. So, as we talked about, thanks, Becky. So, as we talked about, she just walked through is only real if you can pay for it. So, let's, talk about how. So, for housing support and connecting eligible clients, there are about three routes, and I'm going to say some that's not on here first. So, there is the Ryan White services in eligible metropolitan areas, as well as transitional grant aid. That's TGA and EMA, Ryan White services. So, they may have funding in your state or in your area that you can pull for some rapid rehousing funding, et cetera. And there's also HAPA, which is federal HUD's federal housing program for low income people living with HIV and their families. But then there's these other two pathways that also exist that we want to talk about. And I argue the first one is the most important development in the space, at least in the past 5 years. And if you live in one of these states, these 25 states that we're talking about with the 1115 waiver, please, please, please try your hardest. Go to Medicaid.gov to see if your state is eligible, to see if these services are there, because these also touch people who are not HIV positive as well. So the first ones that I talked about with HOPWA and the Ryan White services are for people specifically with HIV. These other ones are for anyone who qualify through Medicaid and they have behavioral health or substance abuse issues. So 25 states now have that 1115 waiver that I was talking about that covers housing related services. That's tenancy support, housing navigation, pre tenancy services. And here's why that's a change that's not just a line item. Housing navigation is a core part of integrated model Becky just described. And in 25 states, it is now potentially reimbursable rather than something you fundraise for. That's a different conversation with your chief financial officer. But issue-based fundraising is something that is on the rise, and I implore you all as we talk more about this to use your data to your benefit when you're applying for grants or when you're working with funders or doing fundraisers. But a few more on that Medicaid side. So community health workers, reimbursement is expanding as well, but it varies. A lot of states, from state to state. Here in Massachusetts, we do have that as a reimbursable fund. Check your own state's billing and codes for that. Don't assume that they have that, even if they have an 1115 waiver, that they may not cover CHWs being reimbursed for doing this work. Mobile services are billable under the Federal Qualified Health Center's prospective payment system when they're delivered by qualified providers. And medications for opioid use disorders and mobile settings are increasingly covered under the state Medicaid plans. The second pathway, the CCBHC, as we call them, or Certified Community Behavioral Health Clinics, are natural partners for mobile programs serving people with substance use and behavioral health needs. They serve the same people, they have behavioral health expertise, and their prospective payment system is built into the support comprehensive delivery. A CCBHC and a health center can co-deploy a mobile team or set up a formal referral agreement or MOU, and it's worth asking about designated collaborating organization relationships. That's the structure that lets CCBHCs extend the reach through a partner like you. Or I also like the thought of embedding someone into from the CCBHC. They also have peers, case managers. They can have people that are doing benefit services as well that are at the CCBHC that can be embedded on your mobile van so that you don't need an extra person to do that. You already have someone who's doing that there. If you take one thing from this slide, take this. The money for the wraparound piece exists in more places than it did 2 years ago. More programs are not asking for it because nobody told them it was there. Let's go to the next slide. Engaging high risk populations. I think this is you, Becky.
It is, everyone. So let's talk about the people we are trying to reach and what it actually takes. And I remember having a little bit of a debate with somebody out here. So I didn't share everybody. I live in Biloxi, Mississippi. And I remember having like a little bit of a debate about some of our high risk populations, like, and just the fear that was there. And I'm like, we might want to do a career shift if we're afraid of the people we are serving, right? And some of the people might be in these high risk populations for a variety of reasons, mainly because we just don't understand. But this is my favorite group, especially our chronically homeless group. These are some of my favorite people to serve because they're a vulnerable population and we just want to love on them a little bit. So let's talk a little bit about what those five characteristics show up over and over among people with the highest HIV risk in mobile settings, right? So our chronically homeless population. So chronically homeless is referred to or is defined as long exposure to environmental risk, and they have limited access to hygiene and high rates of being victimized. So this is why I say this is my favorite group to work with, right? Just to be able to love on them and to just get them to understand that you deserve the services that are being provided. And then we also have our substance use disorders. So injection drug use as a primary transmission pathway and co-occurring opioid and stimulant use. And then we also have people who are living with mental health conditions. So untreated depression, PTSD, psychosis, all of which can affect decision making and make somebody less likely to seek help. Are criminally justice involved or criminal justice involvement folks. So people who are cycling between incarceration and homelessness, which breaks care continuity every single time. And then just system distrust. Prior negative experiences with healthcare, housing, and social services can create a deep reluctance to engage. And I'm not sure if anybody has heard this, but I've heard this several times in my career. Miss, I would rather sleep on the streets than go into shelter. That is problematic. And it makes us sit back as case managers. Even when I was running housing programs, I had to ask my team, hey, are we creating an environment that's more traumatic than the streets? And if we are, how are we going to, as the staff, as the people who are serving them, let's be real, we are serving them to change that environment so they feel like this is a place that not only they can lay their head, be safe and heal. This is the point of a domestic violence shelter, right? To heal and be linked to the services you need. This is why I say these are my favorite groups to serve because not everybody, loves on them the way they need to be loved on. So the last one that gets underestimated the most than anything else is system distrust. And just looking at that, many of the people a mobile team meets may have had bad experiences with every system they have touched. That includes healthcare, housing, courts, child welfare, benefits. So that history is what's in the room when you pull up, which is why those relationships are so important, which means that the first job of a mobile health team is not clinical. Again, it's relational. And Lawrence, did you want to say anything before we go to the next slide?
No, I think that was perfect.
Thank you. Thank you. Thank you. So let's go to engagement strategies that work. So three strategies, all with evidence behind them. One is, like Lauren says, use your data to target your outreach. So point in time counts, continuum of care dashboard. So all of our homeless services, just type those words in and you'll be able to find it in your respective areas. And your local homeless management information systems will tell you where the people actually are and what they are already using. And those are the tools that your community already runs. Don't guess, just plan. Use those things, use those resources that are already there. And then number two is you go where the people can actually reach you. So again, shelters, day centers, food distribution sites, encampments. The whole advantage of a mobile health unit is mobility. Use it. I would add a couple of other places to this list as well. I remember working in New Orleans and the housing providers, from our COC, the continuum of care would actually go to the jail at midnight when people were getting out at 12:05 and would meet and do assessments in the parking lot. Now I know the mobile health unit cannot go out at midnight, right? But maybe looking at, parole offices, whatever it is, like reaching out to the criminal justice provider, seeing like, hey, would it be beneficial here? Like we said, going to the shelters, very key. Actually going into their space helps them. So presence is strategy. And then number three is deploy your peer navigators. And what's crazy is I actually talked to one of my peer navigators yesterday, and it was her birthday. And just hearing the excitement that she has going into community and building those relationships, my gosh, she is just phenomenal. So peer navigators are people with shared lived experience, and they are the most effective engagement tool available to a mobile program. They build trust that clinical credentials by themselves cannot. And thank you, Lawrence. I think that brings me back to you to round us out to talk about why retention is where the outcomes actually live.
Absolutely. I'm sorry I was having more technical issues, but Um, but there are four retention strategies, and I want to, spend some time, speaking on the second one. But the first one is the warm handoff protocol. Never hand somebody a phone number and to call that referral. Introduce them to that person. They'll work with them that they're going to work with next by name with context in a real time. So if you can in real time, please, please, please make sure that there is a warm handoff. Your community health worker and your peer navigator are great for that, establishing the relationship with whoever the partner is, as well as maintaining that and keeping that trust with the partner. The second one is housing as retention tool. And this one changes how you build the whole program. Stable housing is the strongest predictor of care retention in this work. Not the strongest social service, the strongest predictor, which means housing uh, isn't the wraparound around your clinical program. For this group of patients, housing is the clinical variable. And in 25 states, connecting somebody to Tennessee support through an 1115 waiver is a reimbursable pathway, not a favor you're doing off the side of your desk. The third, case management from the first encounter. Assign it at the first contact. Don't wait until somebody misses an appointment to decide if they need support. Benefits, transportation, food, those are all competing priorities that pull people out of care and they're addressable. And the fourth one is and scheduled re-encounter. So go back to the same place on the predictable schedule. Consistency is what builds the expectation that you'll be there and that expectation is the whole retention mechanism. Now, I will say what is key to this is having that handoff and having someone in the middle. So if you can picture this where the screen is right now, if there's an arrow pointing from handoff protocols to housing as retention tool, that arrow is somebody that is holding this protocol to make sure they're walking somebody to that next referral, making sure that they're getting to that medical follow-up that they need to do a confirmatory test, whether that's for HIV or Hep C. And for Hep C, there are protocols out there for you to have a confirmatory right there. And there, I think it's Gen 4, they should already be running a confirmatory test for Hep C in real time there as well. But there should be somebody that is in between those arrows that is saying, okay, we have a newly diagnosed person. I'm going to be that person. This is my card. I'm going to carry you through all of this. It also helps to have something there for the client to have so that they know that what you say is real. And what I mean by that is when I was running my program for Linkage to Care, what we knew was transportation was the biggest barrier for youth 18 to 24, really 18 to 30. Like transportation is a thing. So being able to not only just give them um, a bus pass, but also say what we're going to do is we're going to get you signed up with the MBTA to get you a monthly discounted disability pass because it qualifies under Massachusetts statute. And we're fast tracking that so you'll have it before the end of the week. We just need to work together. It's a great retention tool to make sure that they're coming back to you. We don't want to promise people anything, but one of the things, if we can promise them, hey, we're going to work through these barriers with you, regardless of if they have HIV or not, if you have the service provider that they need and you have the community health worker or the peer navigator there to navigate them to those services, it is a great source of retention for the population.
Hey,
Becky, you have
Lauren.
anything you want to add?
No, but I did want to acknowledge Miss Desiree's hand. She had her hand up, and I'm not sure if she wanted to add
Yes.
to it.
Hi, how are you? Great presentation. I love it. So,
Thank
I've been
you.
in the business for a while, and I will tell you this year has changed a lot. I haven't been successful with testing because remember, stigma still lives. Not everyone is down to get tested or to open their doors for HIV and Hep C testing. So, one thing I will tell you I have done, yes, my numbers has decreased, but my events and my table events with flyers, information, using QR codes to be one on one with people has been pretty good. Um, I live I live in the other side of Pennsylvania. I'm towards Maryland. So we have no transportation. I don't talk about housing. When you're in this position, you got to know what your organization is willing to give, no matter if they have grants or not. So one thing I will say, anyone in this side, because I'm in South Central Pennsylvania, it has really changed the funding and the services that we have. I refer a lot out because if I can't help you in my program, there's other programs out there. I do like to give people other options, no matter if it's a new positive or if it's a client that's been with our program for a while. um, my testing hasn't been successful, but my condoms definitely, they have been flying. I send them out to everyone. um, I do post a lot of stuff on social media to let them know about testing. I am consistent with certain drug and alcohol programs that I hang out with them for 8 weeks and I do groups with them. But I will say, doing outreach this year has been very, very different. It's more listening to the partners and what they want, not what you want to bring to the table. But I got to take it. If they ask for it, I got to satisfy my partners too. The churches have been wonderful. I cannot do
Mm,
testing in the churches, but they will let me advertise for STDs, family planning, and they will let me give out condoms. I think it's crazy. You won't let me do testing, but you let me give out condoms. But
interesting.
yeah, it is. A lot
Is
of
that
my church. Huh?
is that the church's
Oh,
fault,
Bob,
or is
Bob,
that
where I'm
the state?
from, we're like 20 years behind, Bob. This is a very old Christian town. I'm in Franklin County, so I'm between Fulton County and Gettysburg. So it's very different. We have to respect what they want and how they want it. Little by little, I know the doors will open, but it will take time. But I will say, knowing what's out there, what you could offer, I definitely work a lot with Harrisburg when it comes to PrEP because we also have a high population of undocumented patients too. So I have to make sure I'm able to serve everyone when it comes to treatment, testing, or getting their supplies. But it's been interesting. It has. But when it comes to housing, it's very, very hard. The homeless shelter has definitely changed here. They rather have more resources when it comes to medical and behavior health instead of sexual needs, which is very different because it's an older population. And I do let people know older people are still doing their thing. They just, they don't ask for
Mhm.
help, but you see the numbers. But outreach this year has definitely, it's been very interesting how to do it and how to bring it to the community. So I gotta
That's so
say,
interesting.
yeah, it
Let-
is.
I'm going to talk about partnership in this next slide, but can I ask you,
Yeah.
or who is the person, the in-between person for those referrals to make sure that those attract for those external referrals? If the
Oh, I am.
clients are not going, you're the person. And how,
Yeah, I'm the total package. I do the outreach services with the testing and the link to care. And a year ago, I just did my MA certification. Like that, I'm able to do my orders because I do HIV, Hep C, chlamydia, gonorrhea, and trick. So I make sure I'm your best friend. I call you, I make sure I check up on you, I do your testing, I take your information. Within 30 minutes, I know my patient.
that's amazing. Having that person is so important.
Yeah.
Also, I'm assuming you're also the point of contact for that relationship with the partners as well.
Yes, and I work one on one with my caseworkers, and I'm bilingual, so I also help my Spanish people too when it comes to positive.
That's awesome. And that's essentially, thank you so much, Desiree, for coming up. Is there any other comments around that before I move on to this next part? Because I think it's
Don't forget
really
about your
great.
migrant workers. There's
Yes.
migrant workers all over the place. They're definitely in need. Yes, there's been a shortage due to certain laws, but the migrant workers are still here and they also need our services. So I just want to put that out there.
Oh, I talked about them in the last webinar that we did and gave an example of, why it's so hard to track them, but having someone who's trusted in the community where they know if they can come there and get tested, it is
Yeah,
safe, and that they have full trust in you as a provider
yeah,
is major to get. get them the healthcare needs that they have, especially with the services that are free,
Yeah, it's true.
that won't identify them and won't get them in trouble if they have immigration issues.
Now I'm more successful with migrants because I actually go. Like my organizations were start off migrants 30 years ago. But when I go to the farm or when I go to their tiny homes where they all live, like it's cool. They willing to learn because this is something they don't see in their country, like in Mexico, Guatemala. They be asking me questions, and I'm telling you, the men of all ages, 18 and higher, and the women too, they get embarrassed. But it's different when you're in their comfort zone. They're comfortable. You hang out with them. They give you a little private space, and that's another thing. Doing HIV testing outside, it's tough. You got to walk with a mobile clinic, a tent, chairs. But I get the job done.
And
It's pretty
one
cool.
thing to remember, and I want to elevate this. One thing to remember when you're talking about partnerships is you're not actually really selling your program. You can have the best numbers and
Yeah.
have that program. What you're selling is yourself. What you do when
Mhm.
you get there. That relationship is thriving or dies on whoever the point person is that's there, as well as having some type of institutional memory where it's noted who the point person is that you're talking to at this other organization. What have you
Mhm.
done? Having some type of frequency of interacting with them. Those are the type of successful workflows for maintaining partnerships, especially in a larger context when you're working with different industries to find the population.
Yeah.
Community needs assessment is also a really great tool to use so that you know exactly where to go and which partners you should partner with. You'll see we have housing, behavioral health, Medicaid, and local systems. Those are great. These are some that you want to make sure that you have on deck for housing. But those other non-traditional referrals are also important to have if you know your population. So if your health center doesn't do a community needs assessment, or the city or state or county doesn't do a community needs assessment, you should get your hands on at least from if you have a Ryan White program or if you have something,
Yeah, we
get
do.
your hand on the community needs assessment. And as Desiree has said, check off those populations and look at where you're seeing the trends go because they're going to be in these pockets. And whoever it is, whether it's the corner store, the bodega, if it's the person selling, some stuff on the side, they are key people to partner with so that you can promote your program. Churches
Yeah.
are wonderful at this. We did a blood pressure testing initiative. This is just blood pressure, and people are still nervous about it.
Mhm.
And doing that blood pressure testing initiative, we went in there and we had to get the buy-in from the ministers. Once we got that buy-in, they were pushing them to us to come to us to get this, as well as get these other testing, diabetes. We got HIV testing. We started with something small and then we went larger, something that people will get through. Then we became a trusted provider, and then we went larger with including the HIV, Hep C, STI testing. And we brought partners in to do those additional services as well. So it wasn't just on us to do this on that testing day. We had a circus almost of providers that were there at the church after they let out that the pastor endorsed that he went through and got tested as well. He did an example, and like they said, the sheep will follow the shepherd, and do this because it's an encouragement. You have that buy-in.
Yeah.
These other places, like I said, partnership and are the infrastructure that makes the screening mean something. And when a mobile team finds a need, a strong referral network is the difference between connection and the dead end. So you have the housing, so continuum care, the
Yeah.
housing, the state housing finance agency, rapid rehousing, permanent supportive housing providers, recovery housing. Then you have the behavioral health. So I talked about the CCBHCs or the Certified Community Behavioral Health Clinics, the community mental health centers, substance use treatment providers that you may have connections with. That could be internally or externally as well. So be looking because not everybody is comfortable with receiving services sometimes in their community. There's a big stigma around, hey, especially in Black and Brown communities where, hey, I don't want this person to know my business. So I want to go to a provider that's somewhere else. So having a network is really, really, really important to sustain that service, but also having that once a month call with those mental health providers as well is equally as important. And then for the Medicaid, so with whatever organization you're with, if you're with a health center, making sure that they have a Medicaid provider that can come, or a coordinator that can come and provide those services. Managed care organizations, your state 1115 waiver administrators, if you have a 1115, or there's another one called a 1915I waiver, which is more spread, and it is um, substance abuse, behavioral health waiver for housing as well. So you can check your state website to see if you all have any housing waivers. You can even do a Google search that says housing services and Medicaid waiver, and then put your state name in there. Easy as that, and it'll bring up some information. And then finally, your local system, your homeless management information system, or HMIS, is what we call coordinated entry, and law enforcement diversion programs. These are great places for you to connect with and make sure that you have some type of connection. As Desiree said, and we're talking about migrant and immigrant populations, making sure that you are a person who can, be trusted. If they find somebody, they want to come and say, hey, this person needs tested, the police and law enforcement can do a nice little warm handoff to you to get them locked into services once they understand the services that you provide. That's just another one. Each one closes a specific gap. And if you don't know who holds these 4 or 5 in your community, that is the homework coming out of this today. Find out who the COC person is, or who knows the COC people in your organization. Um, uh, Find out if you all do permanent supportive housing. And I'll let Becky come on and talk about what permanent supportive housing and rapid rehousing is in just a second. And also recovery housing. Becky is a wonderful person who has experience working with recovery folks as well. Your community certified behavioral health centers and community health centers are really important. Find them; they're everywhere. You may not know that you have CCBHC in your community, but they are great, and they do both the case management piece and provide therapy. And then again, these Medicaid waivers. But Becky, I'll let you come on and just run through really quickly what rapid rehousing is, what supportive housing is, and then what recovery housing.
Hey, everybody. So, Ms. Desiree, thank you so much for adding to the conversation. You most definitely just gave a bigger context to the conversation. So, I do want to stress that we are over time, but we're going to breeze through the rest of this presentation in about 10 minutes. So, just if you can give us 10 more minutes, I promise you we're going to get through it. But like Lauren said, so rapid rehousing, not sure if anybody's familiar with it, but it is a time limited rental subsidy that is provided. And it's excuse me, because I don't have my stats up right now. So I want to give you the correct stuff, right? But it is a voucher that you can take to a scattered site. Like, so you can go to any place as long as the landlord would accept the client. But it is a time limited intervention that lasts for about anywhere between 1 to 2 years. Really depends on how your program is structured. Permanent supportive housing, I always call that the mental health version of Section 8 or 8 housing choice vouchers. That program, is just is coming in, providing a rental subsidy along with, I'm sorry, a case manager. And that's critical, right? Because some people need that support every month. And then our recovery housing. So we talk about from my lane. So, I'm with Ms. Desiree in Pennsylvania, or used to be. So I was in Philadelphia. So that was our domestic violence shelters, and then our substance use disorder shelters. And what's funny is that it seems like everybody in the state of Pennsylvania, we all transfer out when we do not have resources. So I have very familiar with sending people to Pittsburgh and Johnstown, and even one of my sites, one of my rapid rehousing sites in Pittsburgh, they would send people to Johnstown. So you have to get very familiar with it. So Lawrence, I could pass it back to you to finish this up. Oh, you're on mute.
Absolutely, sorry. And that's why asset mapping is so important. We can't build a referral network if you don't know what exists. And map it across every domain: emergency, transitional, and permanent housing, food, transportation, behavior health, employment benefit enrollment. That is a thing that is coming up, and a requirement for folks who are on Medicaid as well. So that's a real big thing to have a connection with. CSH has a housing asset mapping workbook that walks you through it, and it is yours and the resources, and we'll make sure you have that afterwards. Number two, formalize the agreement. So a memoranda of understanding, which is an MOU, data sharing agreements, written referral protocols, and here's why that's worth the paperwork. Informal relationships break off when staff turn over. So if Desiree leaves, we lose that connection to that provider because she's the person holding that. While it's important that we have those folks that are on the ground and are doing the field work doing that, it's also important for us to have it stored for institutional memory so that if there's a new person added to the team, or if Desiree gets a promotion and she leaves, or whatever the brilliant thing that happens, there is still institutional memory that's there, and we can still service those migrant patients that we have because we have that relationship and we know that where they're going. Miss Desiree?
One thing I want to let you know real quick about housing in Section 8. You know, Section 8 is closed for a while, and the people that do have their Section 8 vouchers in the state of Pennsylvania are picking up and leaving. I have met a couple of clients, not HIV clients, just regular clients that come to my facility that literally one of them went to Hawaii, the other one moved to Mississippi because people are just, the housing situation is getting worse. So whoever can, they got this voucher and they can't find housing here in Pennsylvania. So I'm having people picking up and leave and signing some medical release because that's what's happening. You could get more housing down south than you could do here. So it's becoming a trend right now. So I just want to give you a heads up on that.
That's great. Thank you so much for sharing that.
Mhm.
And what's equally important is make sure that you get informed consent, whether that
Yes.
is, the HIPAA compliant consent
Yeah.
form. Make sure that they sign off on it before you send their information anywhere, unless
Yeah.
that person is right there in the room with you or they're co-located and you walk them
Yeah.
down personally and giving them to the person. Make sure that you get something written and signed that says you consent to be served, and I have your consent to send your information to this referral provider. So important to have. And you can get that while you're having that conversation, while you're doing their testing, finding out that information, have them to sign the forms that they need to do. Two more other things. So engaging the homeless system, the coordinated entry, your homeless management information system, the HMI, they're the backbone of how the community responds to homelessness. If your mobile program isn't connected into it, you are running a parallel to that system rather than inside of it. So the next one, I'm trying to make sure that we are going. So sustain through shared goals. So when you find that partnership, make sure y'all have shared goals and what you're trying to do. Also, make sure that it's bi-directional. A lot of times we show up in these processes and we're saying, hey, we're going to do this or you're going to do this. But we are not saying what you're going to do for each other. And a lot of times that is really important. They just opened the poll around the HRSA evaluation poll. Please fill that out before you all leave. We're going to keep talking. If you have to jump off now, that is okay. I'm just going to keep talking and get through this really quickly. Um, also when you're collecting information from them, share the credit publicly on purpose in written proposals. So if you find anything or you're showing trends or you have that, please make sure that you are crediting your partners as being equally responsible for these findings as well, because you wouldn't do that if they weren't there. Now I'm gonna move on to Becky, who's gonna take us through how actually track any of this.
All right. Thank you so much, Lawrence. Oh, sad that we're running out of time. We always put 60 minutes and we're like, we need 90 every time. So my next one is actually 90 minutes because we're going to make sure that we want to give you time to have that conversation. All right. So we talked about the closed loop referral networks, right? So closed loop referral is the technology layer that makes all of the partnership work operational at scale. And we know that we need to pull those numbers, right? So this is where we can actually use that data to pull those numbers. And the concept is simple in 4 steps. So you have identified the need. Through health related needs screenings, which flag housing, substance use, or behavioral health. You send the referral electronically to the partner organization. Now, Even with me saying it out loud, I can hear Miss Desiree and people in Pittsburgh right now or in Pennsylvania, even here in Mississippi, where they're like, yeah, that sounds good, but we have paper here. So whatever it is, right? You just have to figure out like what does that look like? Sending the referral. Is it electronically? Is it through fax or whatever it is? We would prefer electronic, but we know that some people or some organizations might not have the capacity. And then you also track the status in real time. So pending, accepted, completed, making sure that we are looking in real time. And this is where multiple people, actually, one of my sites on another project I'm on, and they have multiple people looking at that referral network. So it's not just the manager, because the manager can be out. It's not just the case manager. It's everybody in that department has access to the referral system because we do not want any pending or accepted referrals just lingering around. We need these completed. And then the partner confirms the outcome and closes the loop. And here is why this is important for mobile more than anybody else. Your team may not see that person again for days or weeks. You don't have you might not have a next appointment to check in. So without a closed loop tracking, you have no way of knowing whether anything you sent in emotion actually happened. And you might be running on hope. So to eliminate that, let's just figure out a way how we can close that loop. And there are platforms that build this nationally, such as Find Help, Unite Us, and others. And many states and regions are building community information exchanges that connect those platforms across organizations. So the question for your program isn't which vendor, it's whether your state or region already has an exchange that you should be joining. And I'm so serious on that one. I do not believe in recreating the wheel. So what do we have in existence? How can we make it better? Let me just partner over there. And Lawrence will bring us home on that data sustainability. And forgive us, y'all, we are going to be talking fast, but you will get these slides and you will get this presentation where you can slow it down a little bit. So Lawrence, back to you. You're on mute.
Sorry about that. So, six key metrics for a mobile HIV prevention program. So, and I call these the minimal set, not the ambitious ones. So, HIV screening, the share of your patients' ages 15 to 65 tested. That's your primary UDS measurement or Uniform Data System measure, and it's already being reported. So, PrEP uptake, initiations per mobile encounter. This tells whether the prevention side is actually being used or being offered. The linkage to care, the share linked between 30 days of diagnosis. That's the Healthy People's 2030 benchmark. And I did a lot of linkage to care. It's the percent of people linked in care within that first 30 days. Then retained in care or engaged in care is that second appointment within the next 60 to 90 days. And then retained in care, did they make that third appointment a year later? Take that how you want to with that retention. I know that we have this down here around the percentage of patients with two or more encounters in 6 months. But that 1 year benchmark for anyone who is newly diagnosed is really important as well. You'll be able to see if their viral load is suppressed, if it has worked, and if you've been able to do that, we see better health outcomes for the patients, and we're lowering the community viral load when we have that. So the referral completion, this is really important. The share of housing, behavioral health, substance use referrals, all the other referrals that the person may use that were actually completed, meaning that you followed up with them in 48 hours and made sure that they made that referral and they didn't need any additional assistance. If you make that referral, 48 hours is the standard for following up with them and let them know, hey, we're going to call, or I'll be here on this day if they don't have a phone, because that is a case sometimes. If they're not testing positive for anything, but you're referring them out, have a way to make sure that the referral was actually completed. This is one that tells you whether that partnership network is working. And then your retention, the share of patients with two or more encounters in 6 months. We talked about that. And health-related needs screening, the share of mobile patients screened at all. That's the denominator for everything else. Um, Track them monthly, not quarterly, and not when the report is due. Put them on a dashboard so you can see the trend rather than the snapshot. And here's the part that people miss. Report to your leadership using the exact same metrics you report to the funders. So use that data that you report to the funders, just write it out and use that as the measures that your leadership will use as they're talking about your program, as they're doing fundraising for your program as well. It's really important. And you need to make sure that you're helping them understand what those numbers actually mean. So when you get the slides, if you need to do a screenshot of this and what you are wanting to share, this is really important. I will add that second appointment being achieved and tracking that third appointment being achieved as well. It goes against the continuum care treatment cascade that they had up that initiated that 2030 drive to getting us to no new diagnosis. Um, let's see what else. And it defends your program when any funders come. You have that information already handy, especially if they do a pop-up. If you have Ryan White, they do try and do some pop-ins to talk to you. One other thing, so planning for sustainability, 3 pillars, and we'll go through them. Diversify your revenue, mobile programs that survive layers, their funding program, Medicaid reimbursement with that 1115 waiver, funding the Ryan White, some behavioral health dollars, doing clinical embedment through partnerships. The working rule I give you is no single source should be more than half your operating budget. If one is, you don't have a program, you have a grant with a van. And we know what happens when that grant runs out and you're not able to get that money again. Demonstrate the value. Your data isn't just compliance, it's your argument, screening rates, linkage improvements, cost avoidance, retention. A program that can show these numbers has something to say in a budget conversation, especially when your CEO is saying we have to cut money because of X, Y, and Z, especially if you're in a new political environment. A program that can't is a line item. And build system relationships. Get embedded in the local health system, homeless response system, the continuum care, and the Medicaid managed care network, because the programs that are part of those infrastructures are harder to cut than programs that sit beside it. Let's see. 3 things to do this month. One, audit your mobile service bundle. The second one is to identify 2 new community partners. And the third one is to start tracking referral completions. We talked about why these are important, but that first one, that audit should happen quarterly. If you need to know what's happening after you collected 3 months of data, you'll start to see trends where things are falling, especially, again, making sure you have that person who is responsible for referral. And it should be each person who is testing is holding on to their client if they're making an external referral. Pick one of these and commit to it. Do that. And over that following 90 days, look at the trend and see if you made any improvements. That also goes into your metrics. That also goes back up to your leadership, and it wraps up to your bottom line of why we need to keep this program. One last thing, and I'll say also that's not in the slide, is that your biggest advocates are the people that you're serving. Giving that information to them is also very, very important and impactful. As long as you have their support, it's harder to cut your program because the community is saying, we need this program. You need to go and find this because we need this very crucial program to survive. Even if it's also expanding the program as well to include things like dental, to include things like other primary care things and visits that people may have, especially if you're in that migrant population. We partner with, when I was at Cotman Square, we partnered with Harvard University to provide a family van that comes out and does all of these services in one. We provided the HIV testing on board, but they had everything else that we needed, and they made sure, because they don't have a primary care facility, that they referred to our health center. They were located where the community was, and we made that as a strategic partnership because they can't handle that load and we can't handle the load. So they're handling that community load for us that handles all that excess amount of primary screening. They're doing a lot of the other screening for us so that when we get the client, we already have that data. We don't have to spend or charge any extra money to do anything besides confirmatory testing and getting them linked into those services. So I'm gonna keep going. So here's a list of all the resources. You'll get this. You can link to it after you receive that slides and the stuff. And if there's any questions that you have, I think we put Becky's email inside of there. I'll also put my email inside of the chat. if you need any support, you'll get these resources, but you can also reach out to one of us as well, and we can help point you in the right directory if needed. I think that is it. I just want to thank you all for staying on with us. I know this is over by 16 minutes or so, but we really appreciate all you all staying with us. Thank you, Miss Desiree, for coming off and being on camera and adding this real time, viewpoint from it. I'm
Can I
removed from programming. Yes, go right ahead.
can I make a suggestion? You should really do this with the Pennsylvania certified community healthcare workers. I'm a part of
Mm,
the organization. I definitely, I am certified through Temple in Harrisburg, but I will tell you there's not a lot of HIV testers, but there's a lot of community healthcare workers when it comes to HIV and STD prevention. I will let you know in my part of Pennsylvania, a lot of our fundings have been cut. So we have to be very careful what we promote because I'm funded and I have to stay within my barriers, my counties. But I wrote your information down, and I think will be a great presentation for other CHWs out here in Pennsylvania. Um, so I'm gonna keep you in the loop, and I'll introduce you guys through emails and stuff. But I think this would be great, and if you feel comfortable speaking to 200 CHWs here, I'll hook it up for you for free. There's no problem.
absolutely. And we actually we're in the process right now of doing a community health worker series. Actually, tomorrow is the fourth one. It's a four series community health worker training. So we're actually doing that right now. We have some of that stuff up, but we would love to, do some more of this training with
Oh
you
no,
all.
I definitely I agree. Any types of training when it comes to outreach, it's definitely good knowledge because there's all different types of outreach out there. There's for diabetes, HIV, there's foot and care, there's prenatal, but we all come back to the same thing. You all need testing.
Absolutely.
But
Thank you
definitely,
again.
thank you.
Thank you so much. And thank you for that referral. We have, I think, make sure I got your email too. I think Becky, you got her email and stuff as well.
Yeah,
So
I'm writing it down.
Hmm.
I'll let Becky end us with her salutations. But thank you all for staying, and I hope you all have a wonderful day.
Oh, and I was just echo what Lauren said. I think Ms. Desiree, you did exactly what we always want to say. Like, yes, we are the facilitators of the conversation, but you all are the experts. And that's what we always want everybody in here to take away from. Please, when you join these webinars, raise those hands and say
Mhm.
your piece because you add more to the conversation. I'm pretty sure so many of your peers heard similarities. So I just want to say thank you all because, yeah, you stayed 22 minutes after. So we appreciate you all, and I hope you all have a great day.
Have a great day.
Bye.